Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For this breakout session, arterial blood gas is one of the tools physicians commonly have difficulty interpreting. Let us refresh our knowledge with the help of Dr. Apolonio G. Javier Jr. He had his fellowship training in the pulmonary and critical care medicine in the University of Santo Tomas Hospital and is a fellow of the Philippine College of Physicians and the Philippine College of Chest Physicians. This session will be moderated by Dr. Erica Pineda.
Good afternoon. Before I start, I would like to thank the organizing committee for inviting me as one of their speakers for this webinar series. And for the next 30 minutes, I am tasked to discuss about arterial blood gas, and I will discuss step-by-step interpretation of the results of the ABG and how this results useful in our clinical practice. So for my learning objectives, I will emphasize on the indications and relevance for ABG use, and I will also walk you through to the steps of ABG interpretation, and I will also present few cases with regards to ABG and correlate it clinically with regards to our practice. So indications and relevance for ABG use. You will be surprised that when you request for ABG, you will have these following informations. Number one, you can know the acid-base balance. Number two, you can determine the ventilatory and oxygenation status of the patient. And lastly, you can establish the gas exchange dysfunction based on the ABG results. It is standard to request for ABG when we are entertaining a respiratory illness. Most of the time, the main respiratory feature is arterial hypoxemia, less accurately measured by pulse oximetry. We can also check for the ventilatory and metabolic abnormalities may also be present, and ABG also yield more precise measure of gas exchange. And ABG may also provide indications of patient's prognosis. So to know the acid-base balance, it is extrapolated in this equation, the Henderson-Hasselbalch equation. It describes the relationship between the blood pH and the components of buffering system, which is the bicarbonate and arterial CO2. This acid-base physiology allows metabolic component to be separated from the respiratory component. So the parameters of the ABG, it is important to familiarize with these three parameters, the pH, the arterial CO2, and the bicarbonate. The normal pH is 7.35 to 7.45. The normal arterial CO2 is 35 to 45 millimeter mercury, and the normal bicarbonate is 22 to 26 millimoles per liter. Strictly speaking, the normal pH is 7.4. Below 7.4 is the state of low blood pH or acidemia, and above 7.4 is the state of high pH, high blood pH, which is called the alkalemia. So when we talk about acidemia, the arterial CO2 is elevated and the bicarbonate is decreased or low. And when we are talking about alkalemia, the level of CO2 is decreased and the level of bicarbonate is increased. When we're talking about disturbance, like respiratory or metabolic, The other parameters has the capacity to compensate or designed to correct or counteract this disturbance by compensatory mechanisms. Like for example, if we are talking about respiratory disturbance, like here, respiratory acidosis, the level of arterial CO2 is elevated. And to counteract this disturbance is by increasing the level of bicarbonate. And when we are talking about respiratory alkalosis, the arterial CO2 level is low, and to counteract this disturbance is by increasing or by decreasing the level of bicarbonate. On the other side, if we are talking about metabolic disturbance, specifically metabolic acidosis, the level of bicarbonate is low, and to counteract this disturbance, the arterial CO2 level is low. And for metabolic alkalosis, the level of the bicarbonate is high, and to counteract this disturbance is by increasing the level of arterial CO2. This is the outline or the summary of the disorders with corresponding compensatory mechanism. We have, let's start with the respiratory acidosis. The pH is low because of elevated arterial CO2. So the compensatory mechanism is to increase the bicarbonate level is elevated. And for metabolic acidosis, the pH is low because of bicarbonate level is low, and the compensatory mechanism, the arterial CO2 will be low. For respiratory alkalosis, the pH is high due to low arterial CO2, so the bicarbonate will tend to be decreased as compensatory mechanism. And for metabolic alkalosis, the pH is high due to elevated bicarbonate, and as compensatory mechanism, the arterial CO2 level will be high. This is the table of different disturbance with its corresponding expected compensatory mechanisms. So when we talk about respiratory disorder, there is a corresponding increase or decrease of bicarbonate per millimeter mercury increase in or decrease in arterial CO2. The same way, when we are talking about metabolic disorder, there will be an increase or decrease of arterial CO2 per decrease or increase in the level of bicarbonate. If the change is within this range, then the mixed acid-base disturbance is present. For example, if the decrease in arterial CO2 is less than expected, the change, then a primary respiratory acidosis can also be present. So let's talk about now the ventilatory status of the patient using the arterial blood gas. When we talk about ventilation, we are using this formula. The alveolar ventilation is equivalent to the rate of CO2 production over the alveolar CO2 concentration multiplied by the atmospheric pressure, which is the 863 millimeter mercury. So in short, alveolar ventilation is inversely proportional with your arterial CO2. So when we talk about increasing your ventilation or hyperventilation, the tendency is to decrease the level of your arterial CO2 in the blood will be decreased. And when you decrease your ventilation or hypoventilation, the level of your arterial CO2 in the blood will be increased. So when we are talking about hyperventilation or the level of arterial CO2 is decreased, the compensatory mechanisms now will be the kidneys will excrete bicarbonate, and the bicarbonate will now be decreased. And for hypoventilation, or the increased arterial CO2, kidneys will retain bicarbonate, or bicarbonate will be increased in the blood levels as compensatory mechanism. Now, let's talk about the oxygenation status of the patient, or the oxidation status with regards to arterial blood gas. The first question is the patient normoxemic or hypoxemic? When we are talking about normoxemic or hypoxemic, it's the level of oxygen in the blood is normal or lower than normal. So to know what is the normal level of oxygenation, we need to determine first the indices of hypoxemia. And these are the following. When we talk about hypoxemia at room air, we need to look at the arterial oxygen and the O2 saturation. And if we are looking at the level of hypoxemia with supplemental oxygen, we have these three parameters: the arterial alveolar ratio, the alveolar arterial gradient, and the arterial O2 FiO2 ratio or the PF ratio. Now, what is the normal arterial O2? If our patient is below or equal to 60 years old, the normal value is 80 to 100 millimeter mercury. And if our patient is more than 60 years old, we have to compute that every year above 60, you have to subtract it from 80. So for example, if we have a patient 75 years old, this is 15 years old above 60, the expected arterial O2 is 80 millimeter mercury minus 15 is equals to 65 millimeter mercury. And another parameter is the O2 saturation, and the expected O2 saturation of this patient should be more than or equal to 95%. We are knowledgeable about the level of O2 if we are talking about liters per minute. So when we were asked what is the level of oxygen that you are using for the patient, sometimes yung sinasabi natin lagi is what is 6 liters per minute or 5 liters per minute. But if we were asked what is the equivalent FiO2 or the fraction of inspired oxygen, this is the concentration of oxygen in the gas mixture. So we have to compute. And the computation is fraction FiO2 is equivalent to liters per minute times 4 plus 20. So if the patient is hooked to 6 liters per minute, you have to multiply it by 4 plus 20. So it's equivalent to 44% FiO2. Other parameter is the arterial alveolar O2, and the expected normal value, the is equivalent to more than 0.75. And the alveolar arterial gradient, the normal value is 15 plus or minus 5. So for every decade above 30, you have to add 3. So for example, if our patient is 30 years old, that's 3 decades above 30. So expected alveolar arterial gradient for this patient is equivalent to 15 plus 9 is equivalent to 24. But to compute for the ratio and the gradient, we need to know the alveolar PO2. And the alveolar PO2 is equivalent to this formula, which is FiO2 times 713 subtracted to arterial CO2 over 0.8. Another index of oxygenation or hypoxemia is the PF ratio, or the arterial O2 over the fraction of inspired oxygen. So if your patient is below 60 years old, the usual value is 400 to 500. And if your patient is more than 60 years old, for every year above 60, you have to multiply by 5, then subtract it from 400. So for example, if your patient is 75 years old, it's equivalent to 15 years above 60. The expected PF is equivalent to 400 minus 15 times 5 is equals to 325. So if your patient is 75 years old, your expected PF ratio is equivalent to 325. These different indices of hypoxemia is the parameters to prove that the patient is indeed hypoxemic using several formula and computations like I mentioned a while ago. The AA ratio, or the arterial alveolar ratio, is the most accurate because it is not affected by the amount of O2 oxygen being given to the patient. Sometimes I request for an ABG and specifically request to extract ABG at room air. to know the actual oxygenation or if indeed the patient is hypoxemic. But sometimes some patients cannot tolerate without O2 supplementation. So this is the best index or most accurate because it's not affected by the amount of O2 being given to the patient. The PF ratio is also an index, but this is a rough estimate. And the alveolar arterial gradient, this is the index wherein we can determine the mechanism of hypoxemia to know what causing the hypoxemia of the patient. So this is the algorithm to a patient with hypoxemia. So when these parameters prove that the patient is indeed hypoxemic, we need to follow this algorithm. First, we need to check for the level of arterial CO2. If it is increased, we go to the left side of the algorithm. There is a possibility of hypoventilation. And then we have to compute for the alveolar arterial gradient. If it's increased, it can be hypoventilation plus other mechanism. The other mechanism is on the right side of the algorithm. And if your alveolar arterial O2 gradient is not increased, then the cause of hypoxemia is hypoventilation alone. And the possible causes is number one, the decrease in respiratory drive, or number two, the neuromuscular disease like the GBS, myasthenia gravis. Now let's go to the other side of the algorithm. What if your PCO2, arterial CO2 is not increased? Check for the alveolar arterial gradient. If it's increased, you need to check if your low PO2 is correctable with O2. If it's not, then you are considering a shunt disorder, and these are the following disorders with shunt abnormalities in the green box. Number one is alveolar collapse or the atelectasis. Number two is intraalveolar filling, pneumonia, pulmonary edema. And number three, intracardiac shunt, or number four, the vascular shunt within the lungs. And if your O2 is correctable, or your PO2 is correctable with O2, you might be considering a VQ mismatch. And the following disorders in the purple one is the airway diseases like asthma, COPD. Number two, interstitial lung disease, now alveolar disease, and pulmonary vascular disease. But if your alveolar arterial gradient is not increased, maybe the problem is there's a decrease in inspired PO2. Maybe you're in a high altitude or decreased FiO2. This is an eye-opener for everyone that not all hypoxemic patients can be treated by just giving or increasing O2 supplementation. So this algorithm is very important to correct the hypoxemia of the patient. Now, let us go now for the step-by-step ABG interpretation. First question, is the ABG normal? So the three parameters that we need to consider is the pH, the PaCO2, and the HCO3 or the bicarbonate. Next question, if not abnormal, if not, what is the problem? Is it acidemia or alkalemia? And what is causing this acid-base disturbance? Is it respiratory or metabolic? And if it's compensated, is it partial or full compensation? And for the last, is there hypoxemia? Sorry for the busy slide, but this is the flow algorithm of ABG interpretations of disorders with their corresponding compensatory mechanisms. So for example, with your pH is low on the left side of the algorithm, it's below 7.35, it is acidosis. Check for the level of PaCO2. If it's within normal, you are considering uncompensated metabolic acidosis. And if your PaCO2 is below 35, you are now entertaining partly compensated metabolic acidosis. But if your PaCO2 is elevated, your primary disturbance is respiratory, the one that causing below the low pH, and check for the bicarbonate. If it's within the normal, it is uncompensated respiratory acidosis. If it's elevated, it's partly compensated respiratory acidosis. And if it's low, you are considering a combined or mixed respiratory and metabolic acidosis. Then let's go to the other side of the algorithm on the right side. If your pH is above 7.45, you are considering alkalosis. Check for the PaCO2 level. If it's normal, it's uncompensated metabolic alkalosis. And if it's elevated, more than 45, it's partly compensated metabolic alkalosis. And if it's low, below 35, your primary disturbance is respiratory, and then check for the bicarbonate. It fits within the normal. It's uncompensated respiratory alkalosis. If it's below the normal, it's partly compensated respiratory alkalosis. If it's more than normal, you are now entertaining a combined or mixed respiratory and metabolic alkalosis. Let's go on the middle part of the algorithm. When your pH is 7, when your pH is normal at 7.35 to 7.45, it's either normal or compensated. Let's check for the pH. If your pH is below 7.4, it is normal or compensated acidosis. If it's more than 7.4, it's normal or compensated alkalosis. And then check for the arterial CO2. It's more than 45, compensated respiratory acidosis. If it's not, it's compensated metabolic acidosis. And on the other side, if your arterial CO2 is less than 35, it's compensated respiratory alkalosis. If it's not, it's compensated metabolic acidosis. But if your pH, your PaCO2 and bicarbonate are normal, then it's a normal acid-base status. This algorithm is very busy, but this will give you, this will help you to interpret the primary disturbance and the corresponding compensatory mechanisms. So let's discuss some, let's interpret some ABG results. So a pH of 7.30, arterial CO2 of 36, bicarbonate of 18, arterial O2 of 80, and O2 sat 95% at room air. So is it normal or abnormal? So the pH is low at 7.30. This is abnormal. So is it acidemia or alkalemia? Since it is low pH, this is acidemia. Is it respiratory or metabolic? Then you can see that the arterial CO2 is normal and your bicarbonate is low, so it's more of metabolic. Is it compensated? If it's compensated, is it partial or full? So since your arterial CO2 is not compensating, so it's uncompensated. Is there hypoxemia? Your O2 sat is 95, so there's no hypoxemia. So the final interpretation is uncompensated metabolic acidosis with normal oxygenation. Let's go back with the diagram. So your pH is below 7.35. The arterial CO2 is normal. So your interpretation is now uncompensated metabolic acidosis. So let's now interpret arterial blood gas cases and then correlate it clinically. So this is the case 1, a 60-year-old male, heavy smoker with progressive dyspnea with a BP of 140/80, cardiac rate, tachycardic of 110, on tripod position with use of accessory muscles, on O2 supplementation via 4 liters nasal cannula. And these are the following ABG results. Your pH is 7.33, arterial CO2 is 52, your bicarbonate is 24, arterial O2 is 65, and O2 sat of 94%. So what is now your ABG interpretation based on the results? Is it abnormal or normal? So your pH is low. So this is abnormal pH. Is it acidemic or alkalemic? Since the pH is low, so it's more on acidemic side. Is it respiratory or metabolic? Your arterial CO2 is elevated and your bicarbonate is normal, so it's more of metabolic. Is it compensated or not compensating? So your bicarbonate is normal, so this is uncompensated respiratory acidosis, and we'll now check for the hypoxemia of the patient. So to compute for the hypoxemia, let's go back with the indices of hypoxemia. We need to calculate the alveolar O2, and the computation is FiO2 times 713 minus the arterial CO2 over divided by 0.8, and it's equivalent to 192. So to compute for the AA ratio, the PO2 65 divided by your alveolar O2, which is 0.34, and the expected AA ratio is more than 0.75. So with this computation, we can say that the patient is hypoxemic. Let's try another index of hypoxemia or index of oxygenation, the gradient, the alveolar arterial gradient. So your alveolar O2 is 192 minus your PO2 65 and equivalent to 127. So expected at this age is 15 plus or minus 5. So the AA gradient is widened or increased. And when we talk about PF ratio, the expected PF of this patient is 400 minus 8 times 5 is 360. And the actual PF ratio is 181. So based on the expected and actual, patient has hypoxemia. So the full interpretation is uncompensated respiratory acidosis with hypoxemia. These are the following causes or the following diseases that can cause respiratory acidosis. You have your CNS depression by using the sedatives, narcotics, or cerebrovascular accident, neuromuscular disorders, acute airway obstruction, the foreign body by tumor or reactive airway, severe pneumonia, pulmonary edema, pleural effusion, and chest cavity problems like hemothorax, pneumothorax, or flail chest, chronic lung disease like obstructive or restrictive lung disease, and central hypoventilation or OSA. So let's go to the approach to a patient with hypoxemia to know what really causing decreased oxygen of this patient. Is your PaCO2 increased? Yes. So we go to the left side of the algorithm. Is your alveolar arterial gradient is increased? And like we computed, it is elevated. So the possible cause is hypoventilation plus another mechanism, which is on the right side. Then check if your PO2 is correctable with O2. If not, you're entertaining a shunt disorder. And these are the following possible causes of shunt disorder. And if your PO2 is correctable with O2, then you are entertaining a VQ mismatch. And these are the following diseases that can cause hypoxemia of this patient. Let's go now to case 2. This is a 53-year-old male with a 5-day history of fever, cough, and dyspnea, with a blood pressure of 110/70, cardiac rate of 108, slightly tachypneic at 28, and febrile at 38, with crackles on both lung fields, O2 supplementation of 5 liters per minute via nasal cannula, and it's a SARS-CoV-2 positive patient. And these are the ABG results. pH of 7.41, arterial CO2 of 29, bicarbonate of 19, arterial O2 of 62, and O2 sat of 92%. What is now your ABG interpretation? Let's dissect the parameters. Is your pH normal or abnormal? So 7.41 within normal range, but to be strict about it, it's more on the alkalemic side. What is the primary disturbance? If it's respiratory or metabolic, your arterial CO2 is low, that can cause alkalemia, and your bicarbonate is low, it's more of acidotic. So the primary disturbance here is more of respiratory alkalosis. So is it compensating? If it's compensating, is it partial or full? Since our pH is within normal range, so we can say that it is fully compensated. And if there is hypoxemia, we have to compute again for these following parameters or indices of oxygenation. So your AA ratio is low. The expected is 0.75, and the AA gradient is 187. It's widened or increased. The expected value is 15 plus or minus 5. The PF ratio is also low. So this patient is indeed has hypoxemia. And the full interpretation is compensated respiratory alkalosis with hypoxemia. And what are the possible causes of respiratory alkalosis? Here are the following. It can cause, the possible is anxiety, pain or fever, hypoxia, lung diseases with or without hypoxia, like pneumonia, CNS diseases, drug use, pregnancy, sepsis, hypotension, hepatic enceph, on mechanical ventilation, hypothyroidism, and high altitude. So let's go back with the approach to hypoxemia. So is your PaCO2 increased? So the PaCO2 is low, so we can go on the right side. Your alveolar arterial gradient is increased. Yes. Is your low PO2 correctable with O2? If it's not, you're considering shunt disorder. If it's correctable, you're considering BQ mismatch. Now, for my last slide, ABG is an important tool in the assessment and monitoring of respiratory diseases. And ABG results interpretation includes identifying the following: the normal or abnormality of your pH. Is it acidemia or alkalemia? Look for the primary disturbance, if it's respiratory or metabolic, and check for the compensatory mechanism, if it's compensating, if it's partial or full, and the presence of hypoxemia. And of course, all ABG results should be correlated clinically. And with that, that will end my lecture. Thank you.
For our next lecture, a chest radiograph is an important tool for the timely diagnosis of patients during these trying times. Let us learn with the help of Dr. Isser Sugay. He graduated from the Residency and Pulmonary Fellowship Training Program of the University of Santo Tomas Hospital and is currently a practicing pulmonologist in Pampanga, where he is the head of the intensive care units of some of the prominent hospitals in the area. This session will be moderated by Dr. Erica Pineda.
Okay. Good afternoon, everyone. I'm Dr. Sugay, a pulmonary specialist in Pampanga. I hope you're all doing well, and I'm here to, as part of the Tiger postgrad, I'm here to lecture on chest radiograph, interpreting shadows. Okay. Special thanks to Dr. Pichi Natividad. I tried in vain to make my own slides, but I always go back to the best lecturer for this X-ray interpretation in pulmonary medicine. She has the best slides, so I asked for permission to borrow for her slides. Right, so let's begin. Okay, chest imaging in pulmonary medicine. So we have the following factors now. How to read a proper X-ray, or at least how to properly read an X-ray based on an internist point of view or generalist point of view. Okay, so we have to fulfill certain requirements so that a chest X-ray is technically acceptable. When you say technical acceptability, it should be a teleradiograph, okay, which means that it has the qualifications to have proper interpretation of the chest X-ray finding. Okay, the others will follow the interpretation, the ATM-LL, or are there many lung lesions, and the chest X-ray in COVID will also be tackled here. So first, is the chest X-ray technically acceptable or is it teleradiograph? Okay. So first, we have the 4 Ps. Remember the 4 Ps: the position of the patient, the penetration of the X-ray, the full picture, and full inspiration. Okay. This will be discussed briefly in a while. Okay. So for the position, so we ask the audience now, do you think this X-ray is acceptable in terms of position? Now, how will we be able to know? Okay, as you can see in most X-ray films, we have the label or the name of the patient in the left upper image. Okay. Now, we will be comparing a PA view versus an apical. Versus an AP view. Okay. So, as you can see, this is a single X-ray or a single person X-ray, but it was taken on 2 different views. One is the PA view or the postero-anterior view, which is the ideal view for taking a chest X-ray, versus the AP view, the antero-posterior view. Okay. As you can see in PA view, the one on the left, the person here is upright, and while versus the one on AP view, the patient is more or less sitting down, or maybe is on a stretcher and could not stay upright. Okay, so the main difference here is that in AP views, most likely the heart always looks enlarged. Okay, so this is not the ideal setup for doing a chest X-ray. It should be, the patient should be upright. Okay. This is a PA view again. So is this X-ray acceptable in terms of position? So how will we be able to know? Upon closer look, okay, you can see that the spinous process of the vertebra should be in the middle of the trachea. The trachea is the tubular shadow here. Okay, and the spinous process is in the middle. You can see that the patient is not rotated. Okay, you will also see on clearer view or inspection that the spines of the areas of the clavicles are equidistant to each other. Okay, the spinous process is of the vertebra is in the middle, and alongside it are the clavicles. If there's deviation here, it is not a good X-ray film. Okay, looking back at the X-ray I showed earlier, we can see that the right clavicle is closer to the spinous processes than the left. Okay, this means that the patient is rotated slightly to the left. Why is this important? Because when the patient is rotated, there may be false enlargement of some of the chambers of the heart. See, upon closer look again, the spinous process is quite near to the right clavicle, which causes some findings like an enlargement of the chambers of the heart, as mentioned earlier. Now we go to the penetration. Okay, ideal distance from the projector to the body is about 6 feet. Okay, if it goes further than that or nearer than that, there are some problems that arise, which I will be discussing. So, is this film acceptable in terms of penetration? It is. Why? Because we should be able to see the vertebral bodies behind the heart, which we see in the film. Okay? You see the trachea, the spinous processes here. Okay? So it's a good penetration as compared to this one. this film is obviously underpenetrated. Most likely, this film was taken on on an AP view. Probably the patient is on a stretcher, so the PA view is not cannot be done. Okay, why? Okay, first we cannot see the vertebral bodies. Okay, and because of this, we may interpret this as effusion, bilateral effusion, because there are haziness in both bases. Okay, but then again, this may be just because of the underpenetration of the film. This one, on the other hand, might be overpenetrated. Okay, it's too dark. No, in a film like this, we will be missing significant infiltrates in the lungs. Okay, comparing again, this is a very good. This is a the one on the left is a well penetrated film compared to the one on the right, which appears that there's pleural effusion when in fact it is only underpenetrated. This film on the other hand is on the right is overpenetrated. The lungs are too black. If the film is like this, we will miss significant infiltrates such as the one on the left picture. Okay? This is too black. Okay, so this is not a good X-ray film. It is not acceptable. Now we go to the third and fourth piece, the full picture, and the film should be taken on full inspiration of the patient. Okay? Okay. So is this film acceptable? Okay. First of all, this film is underpenetrated because we cannot see the vertebral bodies behind the heart. Okay. Aside from that, the film is also cropped. We cannot see the claustrophrenic sulci on either side. This film should not be accepted. It's a no. Okay. And we will be missing a lot of findings with this kind of X-ray films. Okay. Okay, we go to the fourth P, which is the full inspiration. Okay, this X-ray on the left appears to show pneumonia on both lower lung fields. Okay, but when the film was repeated and the patient was made to inspire fully, we can see that what initially appeared as pneumonia was just crowding in the lower lungs. Okay, so we always make sure that the film was taken on full inspiration. Okay, chest X-ray is pretty much like submitting a passport picture. Okay, we certainly look on the left. We certainly do not want to submit a picture that looks scary because it is not developed properly. Okay, or a picture that does not show the details, or one that is cropped and does not show the whole picture. We want what is complete, clear, and beautiful, of course, facing the front with clear details. This is my my boss, Dr. ABG Natividad. Okay, so after checking if the X-ray is acceptable, we have the 4 P's again. Okay, take note of that. Let us now proceed with how to examine and interpret the film. There are different ways we can approach this. We have these ATMLL, we have the ABCDEF. But I will be focusing on this one, and this is because this is what was taught to me, to us, when we were in med school and in residency and fellowship. Okay, ATMLL, so easy to remember. Are there many lung lesions? A stands for the abdomen, or the abdominal part of the chest X-ray, and then you have the T for thoracic cage, M for mediastinum and the midline structures, and the LL is for the lung lesions. Okay, ATMLL. So you ask, are there many lung lesions? Just remember this and remember the words or the terminologies, and you'll be good to go. Okay. So for the abdomen, we go start from the A muna, no? Abdominal part of the chest radiograph. What do we look for here? We have to look for the level of the hemidiaphragms. We have to look for the right and left hemidiaphragms. We have to look for the contour of the diaphragms and for the claustrophrenic sulci. Okay, so what is the level of the right hemidiaphragm? So we count the ribs to determine the level of the hemidiaphragms. 3, 4, 5, and so on and so forth. Okay, so we have to stress that that the um, the the right we have to stress the importance of looking for the first rib that loops anteriorly first. This is the first rib. Okay, first, second, third, fourth, fifth, 6, 7, 8, 9, 10. Okay. An acceptable finding if of chest X-ray if we have 8 to 10, if we are able to count 8 to 10 ribs. Okay, more than that, there's most likely hyperinflation or air trapping, and less than that, there may be hypoaeration or the patient was not breathing, inspiring properly. Okay, and then we also take note that the right hemidiaphragm is higher than the left. Okay, and we have to make sure that the diaphragm is also dome shaped. Okay, and then we have to make sure that the costophrenic sulci on both sides are sharp. Any deviation from this, that means there's blunting, might be a fluid in the lungs. So let's take a look at this film. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 ribs, okay? The right hemidiaphragm is at the level of the 10th posterior rib and is one intercostal space higher than the left. Okay? Then we can see that both hemidiaphragms appear to be dome-shaped. So we're okay. But we will see that the left costophrenic sulcus is sharp, but the right costophrenic sulcus here is blunted, which may signify fluid or effusion in the lungs. Okay. Okay. In this film, the right hemidiaphragm is at the level of the 12th posterior rib. Okay. Sorry, 12th posterior rib. So there might be a hyperinflation or air trapping, commonly seen in COPD patients or smokers. Okay. You also see here a vertical heart. Very common finding for COPD patients, or yes. And then you can see here that the hemidiaphragms are flattened. Okay. And there seems to be some blunting on the right costophrenic sulcus and on the left costophrenic sulcus, which may be from the effusion or pleural thickening. Now, we proceed to the T part. Are there many lung lesions? We're on the second T for thoracic cage. Okay, these are the things that we look at: the ribs and the intercostal spaces. This should be equal and symmetrical. A narrowed intercostal space may signify atelectasis or trapped lung, while a widened intercostal space might signify pneumothorax or pleural fluid or effusion, and some cases also emphysema. Okay, we'll dig further here. Well, again, this is a normal film. The ribs and intercostal spaces are equal and symmetrical. Now, these are the examples of narrowed intercostal spaces. As you can see on this first film, there's narrowing on the right with compensatory widening of the left intercostal spaces. We will explain this further later. And on the second film, we have widened intercostal spaces here and narrowed intercostal spaces here. Most likely, in the narrowed intercostal spaces, there is atelectasis or lung collapse, and because of that, the widened intercostal spaces are due to compensation or are compensatory. Okay, again, this film shows symmetrical intercostal spaces and ribs. However, when one knows what the normal film looks like, you will also note that or appreciate that the intercostal space in this film, though symmetrical, are widened. Okay, this is because due to air trapping or hyperinflation, commonly seen in COPD patients. Okay, To be able to, of course, it takes practice and it takes experience to be able to see such such widening of intercostal spaces. It would be good not to be reviewing to see normal films or normal chest X-ray films so that you can deviate, so you can see any deviation from the normal. Okay, we go here. Where's the pathology? This film shows narrowing of the intercostal spaces on the left and widening on the right. While initially we may think that the pathology is on the left, no? Although we do not see any atelectasis causing the narrowing of the intercostal spaces, if we look carefully, we will see the visible visceral pleural line on the right. Okay? What is this? No, this is pneumothorax. This is air in the lungs. Okay? Because of too much air, the intercostal spaces have widened, causing the structures to move on the other side, causing compression or causing atelectasis on the left. That's why you have the narrowed intercostal spaces. Okay? Yes, this is the visible visceral pleural line commonly seen in pneumothorax patients. Now, we're done to the A, T, abdomen, and thoracic part. We go to the M. Are there many lung lesions? M stands for mediastinum, and these are the things that we look at. The tracheal shadow, the cardiac silhouette, and the hyla. Okay. The trachea is the tubular shadow in the upper chest. It should be midline. Okay. The heart is also midline, but the left ventricle projects to the left. We do know, though, that the apex of the heart should be found along the midclavicular line. So we can use this to see if the heart is displaced. And finally, the hyla. We can see that the pulmonary artery is in this area, particularly the right descending pulmonary artery. Okay. Always take note that the left hilum is usually higher than the right. Okay. In this film, the trachea is in the midline. The apex is past the midclavicular line. There is no apparent lung pathology causing displacement of the apex, and it is obvious that the heart itself seems enlarged. The normal CT or cardiothoracic ratio is 0.5. Okay, this patient has cardiomegaly or heart enlargement. Another one here. You can see the trachea in the midline. The apex is displaced. The heart is enlarged. You have a very big right descending pulmonary artery. This is called the thumb sign. It represents pulmonary hypertension. Okay, what else do we look for in the mediastinum? Midline structures, contralateral, or this is a very important aspect in the chest X-ray, because from here you will see what the lung pathology is sometimes by the deviation of the trachea and the midline structures in the mediastinum. Okay, contralateral shift of the trachea and midline structures would almost always signify pleural effusion in pneumothorax. Ipsilateral or same area pull would almost always signify atelectasis. Okay, we will explain further. In this film, the trachea and the heart are displaced to the left. Okay, so is it a pathology in the right pushing or a pathology on the left pulling? Of course, you have here the pneumothorax causing a widened intercostal spaces, taking up the space. So it's pushing the structures, the midline structures, to the contralateral side. Okay. In this case, the trachea. Oh, sorry. Okay. In this case, you have the meniscus sign. Okay. Fluid pushing on the contralateral side. Okay. Because of that, the trachea is pushed on the contralateral side, and the heart is also displaced on the contralateral side. So this is a pathology on the left, pushing on the right. Okay. This one. In this film, the trachea and the heart are displaced to the left, but we don't see any pneumothorax here. I don't think this is effusion, because if this is effusion, it should be, the trachea should be pushed towards the contralateral side. Okay? So what is this? Most likely, this is an atelectasis or lung collapse. Okay? Lung collapse due to many factors, mucus plug, or atelectasis from collapse of the lung because of pulmonary mass, maybe. And finally, we go to the lung lesions. Okay, so LL, are there many lung lesions? LL, lung lesions. We look for infiltrates on each lung and compare one lung to the other lung. Okay, so here's how it is. This is how we recommend the lung fields to be examined. So we take a look at the one lung first, then look at the other, okay, and then look at both, so we don't miss anything. Okay, so let's try. For the lung lesions, do we see any infiltrates here or any masses? No. On the left lung, we look from up to down. Okay, here, it seems like there's an infiltrate here, which may be pneumonia. So that's how we catch it. So we don't miss anything, okay? This one. So, okay, let's try to exercise or practice reading a chest X-ray film. Are there many lung lesions? Okay. So, A, for the abdominal part of the X-ray, we look for the hemidiaphragms. We look for the dome. We see that the right hemidiaphragm is higher than the left. The hemidiaphragms look dome-shaped, and there seems to be sharp. There's no blunting of the cosophrenic sulci. Okay. Their thorax. Okay. We look for bony deformities or any fractures. Nothing. No widened intercostal spaces. The ribs are intact. Mediastinum, the trachea appears to be midline. The heart is normal. The apex is at the midclavicular line. So we are past the ATM. We go to the lung lesions. Okay. We look on the right lung first to see any lesions. No. Do you see anyone? Sorry, anything? Nothing. We go to the left lung. Okay. Okay. On the left upper lung, we see cavitary lesion, most likely from tuberculosis. Okay. Other examples here, if we go to the lung lesion straight, you can see cannonball lesions. Okay. This is a metastatic very common for metastatic lung diseases. This may be a primary tumor spreading to the other parts of the lungs. This is also very common in other malignancies, ovarian, liver, causing cannonball lesions. For the lung lesions, more lung lesions, we see here infiltrates on the right with air bronchograms. Okay. Clean on the left. Okay. This is consolidation pneumonia. Okay. Okay. Let's practice again for are there many lung lesions? Okay. We start in the A for the abdominal part of the film. See the right hemidiaphragm to be dome-shaped with no blunting. It's sharp. But on the left cosophrenic sulcus, it's blunted. You cannot see anything. It's mostly white. Okay. There's homogeneous density here. And curved upright border of the density or meniscus sign signifying pleural effusion. Of course, in pleural effusion, we do this left lateral decubitus position. to see if it's really fluid. If the fluid layered, or if it's more than 1 centimeter, it's most likely more than a 500 ml of fluid. Okay, so the fluid has layered, which means it's free flowing fluid. We call it layering. So now we go to this question: is the lesion pleural based or in the lungs? Okay. If we try to measure or try to draw or outline the mass, and if it is an obtuse angle, which means it's more than 90 degrees but less than 180 degrees, it's usually pleural based. Okay. But if you have an acute angle, if you try to draw the lesion or draw an outline on the lesion, the angles are acute here, it is parenchymal. Okay, I will show you further. Or this one. The angles are obtuse, so most likely the lesion is pleural based. See the visceral pleura. Okay, this is pleural base. This is inside the pleura. Okay, the mass or the problem is inside the pleura. While this X-ray, when you draw an outline, the angles are acute, signifying a parenchymal lesion. Okay. Okay, so another X-ray here. Don't forget to look at the thoracic cage. Okay. So let's try to do an ATMLL. Are there many lung lesions, abdominal part? The diaphragm seems dome-shaped, is dome-shaped. There's no blunting on the phoenix sulcus. There's no fluid. Now we go to the T part, or thoracic cage part, the ribs. Okay. I will have to admit, when I was still in training, I always tend to fail to see this one, no? Fractures, rib fractures. So always take a look at the ribs or the thoracic cage part. Okay, you see there's fractures here. We count which level of the ribs: 1, 2, 3, 4, 5, 6. There's fractures on the 6, 7, 8 left ribs. Okay, so you have to take note of that. Now we proceed with the lateral view of the chest X-ray. It is very important to complete the assessment of the lungs and the chest, especially in the areas behind the heart. The lateral film will also help us localize densities, no? Because we might see some things we might not see some things in the PA view that we can see in the lateral view, such as in this case, no? We have here a COPD patient. X-ray is very consistent with air trapping or hyperinflation. Okay, widened intercostal spaces, tubular heart, flattened hemidiaphragms. Okay, and at the back, you will see a widened retrosternal space. Okay, it should not be the case. It should be this way. Okay, there should be no retrosternal space. This is a normal film. Another thing, it is very important, no? Because we have to visualize the posterior gutter. Some films appear normal on chest X-ray, on the PA view of the chest X-ray, but on the lateral view, you see pleural effusion. Okay, this is the part that cannot be seen in the PA view of the chest X-rays. Okay, so we're almost done. We'll be tackling shortly about chest radiograph in the time of COVID. Okay, this is a very, on my part, it's a very emotional topic for all of us, I think. No? We're all, until now, we're still going through this. And I hope it goes away soon. Okay, what is the diagnostic X-ray finding in COVID-19? Well, actually, there's no diagnostic X-ray finding, but some findings will help us or give us a clue if we highly suspect of COVID-19 infection. Okay, you go to the first table, first row. A typical finding would be a multifocal peripheral consolidation and multifocal rounded opacities and nodules. This is very most likely almost all of us have seen such films. Okay, and just to point this out, some atypical findings may be due to COVID, but must consider other causes as well. If we have focal lobar consolidation, not bilateral, pleural effusion, peripheral interstitial opacities, bronchial wall thickening, atelectasis, and lymphadenopathies, we should be thinking of other diagnoses as well. But I'm not saying that this cannot be found in COVID, but we consider other problems as well. Okay. So just a common finding in COVID patients, you have bilateral peripheral infiltrates progressing. Okay, what we need to know, a normal chest radiograph does not exclude COVID-19 pneumonia, and no single feature of COVID-19 pneumonia on a chest radiograph is specific or diagnostic, but a combination of multifocal peripheral lung changes of lung-glass opacities and or consolidation, which are most commonly bilateral, may be present. Okay, just small summary of the potential chest radiograph findings in COVID-19 pneumonia. Most patients with COVID-19 infection have mild illness and do not develop pneumonia. The chest X-ray may be normal in up to 63% of people with COVID-19 pneumonia, particularly in the early stages. Some findings include lung-glass opacities, coarse horizontal linear opacities and consolidation, okay? And these are more likely to be peripheral and in the lower zones. And bilateral lung involvement is most common, okay? But it may be unilateral in 25% of cases, although so far I always see bilateral involvement of the lungs. So we have tackled chest imaging in the pulmonary medicine. We have discussed technical acceptability, interpretation, the ATMLL, and chest X-ray in COVID. So again, just a summary. Is the chest X-ray technically acceptable? We have to look for the 4 P's. The position, PA view, 6 feet away. Okay, the penetration, the full picture. We should see the sulci and the other structures that should be seen in chest X-ray, and it should be taken on full inspiration. Another review, ATMLL, please take note of this. Are there many lung lesions? Okay, which comprise of the abdominal part of the X-ray, the thoracic cage, the mediastinum and the midline structures, and the lung lesions. COVID-19 chest radiograph. COVID patients may have normal chest films. It's not diagnostic, but it will aid us in diagnosing patients with COVID-19. And most common finding will be bilateral, multifocal peripheral infiltrates, and ground glass appearance. And that's about it. Thank you so much.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.